So my goal today is to speak about bone loss. When we speak about bone loss, we have to keep in mind that in chronic anterior inferior instability, we face with the bipolar bone loss. It means on the humeral head and on the glenoid. So we have to keep in consideration them both. Humeral head and glenoid, of course. Before the glenoid track, we used the engaging, non-engaging, and had a very nice discussion with Steve Burkhardt. The problem of engaging or non-engaging that we tested the shoulder stability of the engaging before the bunker repair. But as Pascal, as Iji, and as Steve Burkhardt recognized, it's important to see if the heel sacs engage or does not engage after the bunker repair. This is very important. We knew that if it was not engaging, we could do a bunker repair, probably a remplissage today, but if it was engaging, we need a bone support procedure. Our consideration so is to try to see if the heel sacs does or not does engage after a bunker repair. According to us, all the heel sacs are engaging. Any heel sacs engage. It's up to the position, the angle, and the force that you are able and you have the courage to apply to the shoulder. So first definition is that any heel sacs lesion is going to engage. The big question is, once again, to know if it's engaged after a bunker repair. According to this study, only 7% engage if you perform a very good, from technical point of view, bunker repair. When arthroscopy versus open, we know very well the parameters that Pascal used. According to on-off track with Matt Provencer, we try to improve the HEAT score with the GTM score to study to improve the bipolar bone loss according to the on-track and off-track lesion. What means on-off track lesion? To understand this, we have to read, of course, this article that we published on arthroscopy more than 10 years ago. And to understand on-off, we have to have clear what is the glenoid track. The glenoid track is the blue part of the humeral head that in upper position guarantee the stability of the humeral head of the glenoid. The glenoid track is 83% of the glenoid width, and you have to measure it medial to the footprint. So the blue zone is very, very important because it guarantees the bone buttress support, and very, very important is the location of the heel sacs. If the heel sacs is completely within the glenoid track, the definition is on track. You have a good bone stability. The problem is when you have a large or, very, very important the message, a medial heel sacs, you have an instability bone support. And we define this off track. In this case, you need a bone procedure. But interesting is that you have to consider the bipolar. The more bone loss on the glenoid you have, the smaller is the width of the glenoid. The smaller is the width of the glenoid, the smaller is the glenoid track. The smaller is the glenoid track, the more possibility you have that the heel sacs is off track. So, according to the glenoid track concept, you are able to study the interplay between the heel sacs lesion and the glenoid bone loss. How to measure? You can measure with MRI, even if we prefer the CT scan. Because with the CT scan, we have a better view of the bone, as you can see, and very, very important is to respect the entry angle. So you need a very good radiological technicians. You can perform a subtraction of the humeral head to have the best view of the glenoid. Of course, you have to measure the glenoid width, like in this case. You have 83%. You put 83% medial to the footprint, and you can see very clearly on the 3D reconstruction if the heel sacs is within or is outside of the glenoid track. The first one is on track. If, like in this case, the heel sacs is outside, it means medial. This is the main message of today. not is it so much important to measure the millimeters, but to see how much medial is the heel sulcus. The more medial is the heel sulcus, the more possibility you have to have an unstable, bony shoulder. Case 2, glenoid bone loss. Of course, the more glenoid bone loss you have, the smaller is the glenoid tract. And as I said before, the smaller is the glenoid tract, the more possibility you have that heel sulcus is off track. Is it difficult to measure the glenoid tract on the CT? Yes, of course, it's an issue. And with HIGI, we are trying to improve this. How? We did an experiment. This is the right shoulder. You can see very clearly the humeral head. You can see the footprint, the cable, and the insertion of the cuff on the humeral head. This is the insertion of the cuff, medial insertion. We know that the glenoid tract is 83% of the glenoid width, so we measure on the specimen the glenoid width, and we say medial 83% of the glenoid width respect to the footprint. And this is the glenoid tract. For the experiment, we put tantalum on the footprint and on the medial part of the glenoid tract. So we have tantalum on the medial and on the lateral part of the glenoid tract. Then we perform a CT of the specimen, and this is your view. You have the medial and the lateral part of the glenoid tract, because to have a good exposition to the CT of the glenoid tract, of course, is the key point to know if the heel sulcus is on or if the heel sulcus is off. And according to HIGI, if you look at the indentation between the humeral head and the tuberosity, you have the first point. And if you give a look to the inferior part of the humeral head, exactly here, you have another indentation. And if you make a connection between these two indentations, you have the medial, the lateral part of the glenoid tract, the part of the glenoid tract that is close to the cuff. Then you can measure 83% of the glenoid width, and you have the most medial part. So between the two dotted lines, you have your precise glenoid tract, and you can see and you can look exactly which is the position of the heel sulcus. That can be outside, and we define this off track, or could be inside, and we define this in track. Thank you very much.